need to identify and train GBV focal points in all health facilities to be able to work together with the GBV team and support to ensure that services for survivors are available in the health facility. And we need to identify or establish private confidential spaces for consultation within health facilities. We need to train health facility medical and non-medical staff on GBV guiding principles for supporting a survivor and providing safe referrals. These guiding principles are very important in GBV case management or handling GBV survivors because it spells down the wishes, respect, non-discrimination, non-judgmental. It spells down how survivors should be treated. We call it survivor-centered approach, and it lays down all these principles, like confidentiality, respect for survivors' wishes, ensuring non-discrimination, non-judgmental, and all this. Yeah. So you find that all of us, we need to work with communities to increase awareness about the availability of services, because the services are not for us, the service providers, but rather is for the community to benefit from it. And therefore, we need to collectively create awareness about gender-based violence and the availability of services. Yesterday, we shared key messages that should be used, whether be in the health facility, whether be with our outreach team. Yeah, we should also ensure ethical, safe, and appropriate data collection methods are in place. We have to make sure this is very critical, because if we collect data and we don't protect data, this means that this information can leak anywhere, and this could put survivor at risk. We have to remember that it's done there. I can't see it, but I know what it's talking about. We have to remember that we are, as GBV team, we are working with the health team. We are not their supervisors, but for the sake of, providing services, we need to work together. We are not coming from the perspective of supervisor of health team, no, but we are coming in the capacity of collaborating with the health workers to ensure that our services are available for survivors of gender-based violence. We talked about justice, safety and security and justice, but we have to remember that ensuring life-saving care is a priority, because we see that people say that we need to ensure that there is justice. We need to ensure that we fight against impunity, and all these are very important. And there are also services that are meant for a GBV survivor, but that can only happen when a GBV survivor is treated and is alive. Otherwise, you will look for justice for a dead person, which will not help. We first make sure that we provide life-saving services before we start crying for justice. And if we do it well, we can save life, and at the same time, we can also get that justice. Many times, these act as barriers. Police would want to have data first before a medical team act, and medical team miss up the 72 hours time. And at the end of the day, you are unable to provide services that would really save life. So moving forward, I remember in Clarendon last year when we had this training, this came up to be a very strong area that needs to be, addressed. whereby, the service providers who are not supposed to be in the hospital at that time or around where survivor is treated. Everyone is surrounding the place and documents are being requested for. Police is here, medical people are here. It's so crowded. And so this chase survivors away from reporting to get services, and we will not be able to save life. And these are the kind of practices that we need to watch as we go about providing life-saving services to survivors of GBV. Any delays can cause a lot of problem or negative effects. Yeah. In some cases, there are no there are no staff, there are no medicine, there are no services at all. But what do we do? So we need to look at this. What do we do if there are no services? What do we do? In terms of medicine and all this, we should advocate to expand services where there are no services, because the services are critical, and the survivor cannot walk like 2 hours or 1 hour looking for services. Probably there needs to create like mobile services where GBV team go together with the health team in the same car or in the same convoy, reach there, everyone do their part, and referral system is in place, and a lot of life is saved. That could be one of it. So this requires that we do it in a well-coordinated manner. The guiding principles I've already talked about. So for us to ensure that services are in place and in a timely manner, we must make sure that there is referral pathway. And this referral pathway have to be updated, because in most cases, we find that the areas that have been disrupted, there are services that are pop-up services, and the referral pathway are not updated to that context. We do have referral pathway that is speaking to like Kingston, but when you go to, say, Black River, when you go to Treasure Beach, when you go to, say, Santa Cruz, you may not get the referral pathway that speaks to the local context. So that means that a survivor cannot travel to come up to Kingston to get these services. How do we make sure that we have up-to-date referral services where a survivor can get services from where they are? And how can we improve on services, including mobile services to these locations that need services? Challenges in the implementation and the coordination. Lack of understanding of GBV, not a priority in many cases. Even when it comes to funding, I see that we don't even get funding from the core resources. I mean, from this, like some critical funding for emergency, GBV is never prioritized. So you find that we are the area of GBV is not addressed, and yet the magnitude of the problem is huge. And also people ask about data. There is no information, but we are informed that wherever there is emergency, we have to assume that GBV is happening. Then there is, of course, limited capacity like medical, legal, psychosocial. Law in the country sometimes may have its own, ways of application and might not be fast, but I believe our law here is very, it's up to date and needed. Yeah, lack of comprehensive and integrated approach. Medical team, they go by themselves, do their work. The GBV team, they go by themselves, they do their work. There is no coordination in between. At the end of the day, survivor is not supported. So this makes it very difficult for the health team and the medical and the GBV team to save life, or even to provide the life-saving services that survivors need. Up to there, are we together?
Yes, Mary, I know some healthcare workers may need to pop off soon. So
Yes,
maybe
please.
if we can in the end share for them to peruse further. Just
Okay.
that everybody gets a bit of everything if it's okay. Thanks, Mary. But we are together and it's going well so far.
Okay, I'm about to conclude. Yeah, as we provide these services, we are reminded that we should be mindful and not to abuse person who is vulnerable. We should not abuse our power because we are powerful. We are going out there to provide services in terms of food, medical services, awareness, dignity kits, and all this money and all this. The community is affected and they are more vulnerable. They need us now. And therefore, we should not turn against them by exchanging our services for sexual favor or for money. That is where we talk about sexual exploitation and abuse. So this means that actual or attempted abuse of a position of vulnerability, differential power, or trust for sexual purposes, including but not limited to profiting monetarily, socially, or politically from the exploitation of another. We have to be very keen. The law of the country is very much there, and it is against any sexual offense. And we must take this seriously because sometimes we are overtaken and we ask for exchange of food, of items that are entrusted in our hands to the people who are affected. We ask for sexual, we ask for money, we ask for favor sexually. This is not acceptable. And for us, there are about 6 code of conducts that we follow. And the first one is saying that sexual exploitation and abuse constitutes acts of serious misconduct and therefore grounds for disciplinary measure, including summary dismissal from your job. For us, the humanitarian, the UN and the partners that they are working with. Sexual activity with children is prohibited regardless of the age of majority or age of consent locally. In a local context, there could be age of children, say maybe is lower than 18, and the standard is 18. And mistaken belief in the age of a child is not a defense. It's not even heard. I mean, no one can listen to you, Yeah, so exchange of money, employment, goods, or services for sex, including sexual favor or other forms of humiliating, degrading, or exploitative behavior is prohibited. This includes any exchange of assistance that is due to beneficiaries but is done, is turned to be in favor of sex or otherwise. This is prohibited. And sexual relationship with beneficiaries are equally prohibited because it inherently done under unequal power dynamics. So it is prohibited. It's not allowed at all, prohibited. And where any of you or any of us will develop a concern or suspicion regarding sexual exploitation and abuse should report immediately. And there are systems in the UN. All these organizations in the UN have their reporting focal point. You need to report so that the cases are addressed. They said report concerns or suspicion. They did not say investigate, okay? When you see that something is wrong, report it so that the team that can do investigation can carry out with their activities. Staff and related personnel are obliged to create and maintain an environment that prevents exploitation and abuses. Managers at all levels have particular responsibility to stop or support and develop systems that maintain this environment. So in this case, where does this principle falls and who does it applies to? It applies to all of us, the UN, and also like the uniform personnel, especially among the UN, and all partners who enter in a contract with the UN, including NGOs, like the grassroots or local organizations, civil society organizations that the UN work with. For example, they might have given them funding and all this or provide support to them. These principles, these 6 principles applies to them. This is done so that we protect the most vulnerable and affected population out there. Thank you, and over to you for any questions.
All right. Thank you so very much for an awesome presentation, Oyela, Miss Oyela. So want to say thank you. Excellent, excellent presentation. I'm sure our participants will agree. Because of time, we will defer the questions a little bit, and then we will now move on to our next presenter. But excellent presentation, excellent presentation. So our next presenter is none other than Suela Abod. Apologies if I'm not pronouncing that correctly. She is a clinical management of rape and mental health and psychosocial support specialist. She has over 18 years of experience in humanitarian and development context as a frontline healthcare worker, providing SRH service for women and girls, including caring for survivors of sexual violence and intimate partner violence. She has a master's in science and health management from University of Telematia International, and she also has an advanced postgraduate diploma in global reproductive health from St. James Lind Institute, and she has a psychology and counseling from University of Nairobi, a diploma in clinical medicine and surgery from Kenya Medical Training College. And this afternoon, we want to extend a warm welcome to Suela to present on the clinical management of rape and mental health and psychosocial support. Warm welcome. Over to you.
Thank you so much, Camelia. I appreciate it. I will.
You are so welcome.
Share my screen. Let me know if you see it. I think we're good. You can see my screens clearly, right?
Yes, we can clearly and hear you well.
Yeah, it's seen well.
Thank you. So thanks very much, and thanks to my colleague Mary for setting the scene. I will take over from where she left and dive into the presentation on clinical management of rape and mental health and psychosocial support. I must say that it was very difficult to summarize this presentation into a 20-minute presentation because the subject is very huge and vast. So I tried my best to give a little bit of highlights, and then hopefully we can organize other sessions to talk more about the specificity of clinical management of rape and mental health and psychosocial support. So since Mary has set the scene already on what has happened, the disaster, and how it has affected the population in the different countries affected, including Jamaica, I will not go into details on setting the scene. I will highlight about clinical management of rape and MHPSS programming in emergency. I will also talk about priorities of clinical management of rape. What is the comprehensive package? What are we expected to do during an emergency concerning clinical management of rape? And how do we integrate mental health and psychosocial support in our different programming, be it sexual and reproductive health, gender-based violence, and clinical management of rape programming? Because mental health and psychosocial support is something that is cross-cutting and should be integrated throughout all the response by all sectors. So from education to health to protection, MHPSS is cross-cutting. But today for this session, I will talk about MHPSS integration in GBV and in SRH. And then lastly, we will look at how we can have a harmonized approach. So as I said, we've already set the scene. We know what happened. You know better than me how this Hurricane Melissa has caused suffering and damage to infrastructure, has led to stressful situation and dangerous situation for the affected population, which include the community as well as you as the healthcare providers, and leading different sections in the response. So that alone, the disaster alone, as the hurricane, is causing a lot of stressful situation. However, including that, we also know that during disasters, during emergency, we do have increased cases of gender-based violence, including sexual violence and intimate partner violence. And this sexual violence and intimate partner violence, which is increased during disaster, equally cause both long-term and short-term impact to our survivors. And some of the impacts of sexual violence is mental health impacts. So for mental health, we have long-term impacts and also short-term impacts. So in mental health, we would have, the community experiencing maybe acute stress or anxiety, or other long-term effects like post-traumatic stress disorder, depression, anxiety, sleep disturbance, substance abuse, self-harm, suicidal behavior, and so forth. But let us not think that everyone would have mental health disorders or mental health concerns because a disaster has happened. No. We know that in disasters and communities that experience disaster frequently do develop some type of resilience, and they're able to cope with the situation more and more as they have this multiple disaster happening to them. But we still do have certain people that have higher probability, or their risk is elevated in terms of having mental health impacts. And we have already said that survivors of gender-based violence or survivors of rape or intimate partner violence are some of the people that they have an increased risk of experiencing mental health impact, including also pregnant women, including single mothers, including teenagers who maybe pregnant teenagers, or even teenagers at large, because of the different age group that is very special as adolescent. So we have to ensure that we are integrating all our programming, we're integrating MHPSS in it. As UNFPA, we do not conduct like standalone MHPSS programming. For example, a disaster has happened, we do not just send people to go and provide mental health and psychosocial support to the whole community. However, our MHPSS or our mental health and psychosocial support is integrated within our gender-based violence programming and within our SRH interventions. So it's not done as a standalone. And maybe you will see this is the difference that we have between UNFPA and other actors who may be providing mental health and psychosocial support during the response. And also when I talk about the different levels of mental health and psychosocial support interventions, you will see that we also do not provide very specialized mental health and psychosocial interventions, but we work more with a community-based approach and working with low-skilled trained personnel, or but not too much into psychologists or psychiatrists. So I hope I will be able to flesh that out as we go deeper into the presentation. First of all, I wanted to share the guiding framework when it comes to clinical management of rape in emergency. We have two guiding frameworks. We have what we call the MISP, or the Minimum Initial Service Package, which is a set of priority SRH activities that must be implemented within 48 hours of any emergency. So this has 6 core objectives, and one of the objectives is to prevent and respond to the needs of survivors of sexual violence. So it is a core or an essential intervention that UNFPA coordinates during any emergency to ensure that the community or the affected population have access to prevention and response to the needs of survivors. So one of the frameworks that we work with is the MISP framework that falls under sexual and reproductive health. The next framework is the GBV minimum standards, which Mary has already spoken about. And one of the GBV minimum standards is to ensure that there is availability of clinical management of rape, and the GBV actors are able to refer the survivors to health facilities or to hospital to access these services. So as UNFPA, we do have a close collaboration between GBV and SRH interventions. We use an integrated approach where we work together, we coordinate the services, and we ensure that women and girls who are mostly affected with gender-based violence or cases around sexual violence and intimate partner violence have the access to these services. So this is just the foundation, so that if we want to go back and read more about what are these other services that need to be implemented under the minimum initial service package that come together with the prevention of sexual violence, we can go and reflect on that. And also we can go, if we have more GBV actors here, we know, like, our Bible is the GBV minimum standards that we always use when implementing GBV in emergency interventions. So I wanted to highlight what are some of the priorities that we need to scale up on clinical management of rape during emergency. We might already be having, some sort of, I'm sure I've worked in a hospital for 10 years back. So many of our doctors or nurses or clinicians do have some knowledge on how to attend to survivors of sexual violence. I imagine that we do have that, because from my time, we never had like specific training that targets health workers on clinical management of rape, but somehow we learned on the job on how to attend to survivors and so forth. So during emergency, we need to make sure that we are scaling up certain priorities on clinical management of rape. And some of the priorities is what I'm going to highlight today, beginning with enhancing clinical management of rape coordination of partners and stakeholders through existing working groups or technical working groups. I'm not sure if we have already an SRH activated working group in Jamaica, but I imagine if it's not an SRH working group, we do have some sort of coordination where actors are meeting with the Ministry Health and Wellness together with UN actors or NGOs, and they're discussing different health priorities. So we need an enhanced CMR coordination to make sure that we know that clinical management of rape is available where, who's offering the services, and what are some of the things that need to be scaled up. Also, we need to enhance our advocacy for clinical management of rape prioritization, because it's one of the key minimum initial service package objective that needs to be implemented within 48 hours of any emergency. Because I know we work in you know, when it comes to health, there'll be many priorities that we want to attend to. Sometimes we tend to put aside, maybe we say, for issues of clinical management of rape, maybe we will do it later, or we don't have the capacity now. But since we already know, we have evidence throughout years to demonstrate that there is increased gender-based violence during emergencies, so we need to advocate for prioritization of clinical management of rape. So this is one thing, to ensure that we are advocating for it, as well as having funds or resources to implement the CMR interventions. And then the other thing is to ensure that clinical management of rape service provision is available in health facilities nearest to the affected population, including access to safe abortion care. Mary already mentioned that, you know, when there are disasters, maybe people are not able to access their normal family planning or contraceptive methods, maybe they don't have condoms and so forth, or we know that they may, you know, be faced with sexual violence. So as we are providing clinical management of rape services, we also need to ensure that there is access to safe abortion care for those who need to utilize this service, of course, to the full extent of the law. Also, another priority is to ensure that we are having an integrated approach for clinical management of rape. So integrating gender-based violence, sexual and reproductive health, including MHPSS. I was really, really impressed to see that the Ministry of Health is not just Ministry of Health, but Ministry of Health and Wellness. So that demonstrating that we are looking at health at large and not just, you know, being the availability of someone being healthy with no disease, but also thinking about the mental health. Honestly, I was really, really impressed with this. And because this is not a norm in other countries, as much as it may look like it's is simple, but in other countries, we need to advocate for mental health, for well-being, and so forth. So I was really happy to see that this understanding is already at a good level in Jamaica. And then other priorities to scale up is to ensure the availability of interagency reproductive health kits. These are kits that normally come with all the needed antiretrovirals for prevention of HIV, the emergency contraceptive, and then sexual transmitted infections for prevention of STIs. Again, I also kind of looked at your Instagram page and I saw that you were promoting some kind of cubes that are delivered in hospitals that have all this medication. So this is the same approach. We have these kits that UNFPA is coordinates. So these kits include ARVs, include all the medicals, essential medical supplies that are needed to treat survivors of rape. So that we should ensure that that is available. And if we do not have the kits as the interagency reproductive health kits, we need to ensure that these ARVs, these emergency contraceptive pills and STIs are in the facilities. So if we have a hospital like Black River Hospital that has been destroyed and maybe the warehouse is not in good shape and the supplies are destroyed, then we advocate to order for these kits that are delivered there that have everything that is needed to attend to survivors of rape. And then another thing that needs to be scaled up or prioritized is to ensure that we have a comprehensive clinical management of rape mapping. And what I mean with this is to have a mapping that shows which facilities have this essential medication and supplies for treatment of survivors of sexual violence, which we call them PEP kits. And then also the mapping indicating which facilities have trained healthcare providers that can attend to survivors of rape. And then we also have confidential spaces also saying like this hospital has available confidential spaces to attend to survivors, because these are very crucial to put in place before we attend to survivors, and I will speak more into it in my following slides. Also, the availability of trained personnel on comprehensive clinical management of rape and IPV competencies. I would like to say that this is an orientation on clinical management of rape and intimate partner violence competencies, but this orientation is not enough to give us the practical skills or competencies that are needed for healthcare providers to provide clinical management of rape services. The training for clinical management of rape and intimate partner violence is 5 days. The global training is 5 days. And so this is just an orientation to give the high antennae to know that we need to do this, but I do not consider this as a, a comprehensive clinical management of rape training. We also do have an e-learning that I will also share a link later on that you can have access to. It can take you maybe 5 to 7 hours to complete the e-learning on clinical management of rape and IPV, which also gives you more information on what to expect or what to do, and give you like specific details on how to approach a survivor. Because if we are not trained, health workers may also contribute to being barriers to accessing of care for survivors. Another thing that we also need to put in place is to monitor the quality of clinical management of rape service provision through health facility assessment and capacity assessments of our health workers to ensure that they're all at par and all are serving the same quality that we would like to see, because this involves people's lives, it involves people's wellness, and that is a priority, I believe, for this, for all of us. And we also we need to ensure that clinical management of rape data is collected, analyzed, and contributes to evidence-based programming. So as much as we are setting up, the infrastructure, ensuring that we have the supplies, we have the trained providers, it's very important that we're also capturing this data that will be analyzed later, and we can reflect back on it, and also it helps us in evidence-based programming. So as I mentioned before, we do have some minimum requirements which are essential to have in place before offering clinical management of rape services. It is a minimum requirement. It's essential. It is a must. We have this in place before offering clinical management of rape services. First thing is having a protocol or a standardized operating procedure that guides how we manage survivors of rape. Where in a country that does not have maybe their own national clinical management of rape guideline or standard operating procedure, we normally refer them to the Global Clinical Management of Rape and Intimate Partner Violence Survivor guideline, which I have also attached in this presentation, and you may be able to see the link on what is included. And also, if we have our clinical management of rape guideline as a country, we would also want to look at our own protocol and compare to the global standards and try to see, are we at par with the global standards? Are there any things or anything issues that we need to improve, and so forth? So that's very important. And then training on how to ask on minimum, on how to ask on first line response. I think there is someone who's going to talk more about first line response, but before we put ourselves in a position where we want to identify who is a survivor of GBV or who is a survivor of intimate partner violence, we need first to have received a training, because sometimes we may tend to use language or words or an approach that might not be survivor-centered, that may do more harm than good. Another thing is to ensure we have a private setting where when we are attending to our survivors, there is no one that can hear us or see us as we are conducting that consultation. Because, in many emergencies, sometimes we have, the damaged infrastructure. So maybe we're setting up tents or we're setting up mobile or temporary clinics, and maybe we're not ensuring we have privacy. And this may tend to put the survivor at risk when we are conducting the consultation. So this is one of the minimum requirement that needs to be in place. Next is to have confidentiality ensured. Again, if we do not ensure confidentiality for our survivors, we might not be receiving anyone, not because people are not there that have been affected or have faced sexual violence, but it's because they may think that if I come to this hospital or if I'm attended by so and so, all my story or all my issues will be out and everybody will know what happened to me. So if we don't have this privacy, this ensured confidentiality, then we may tend not to have people coming back or coming at all in our health centers or our hospitals. And lastly, we need to have a system for referral in place. As I always say, when attending to survivors, as healthcare providers, we are just one leg of a table or a chair, and it cannot stand on itself. So for us to provide holistic services to survivors, we should be able to refer them to other services beyond health. It could be case management services, psychosocial services. It could be related to access to legal services or access to shelter. So if that referral is not in place, also it means we need to work on our minimum requirements before we jump into saying that we are providing clinical management of rape services or services to survivors of intimate partner violence. So I wanted to highlight that, and also highlight that there is a curriculum that we recently worked on, both this guideline and both this curriculum on training health workers. UNFPA has actively participated in the development of these two guidelines. And of course, I'm sure with discussions with UNFPA in your country, you might be able to see how they can support in terms of conducting this training or orientations for other providers. So moving forward, that was on clinical management of rape. I also wanted to highlight on essential requirements for MHPSS programming. So just as clinical management of rape, there are some essential requirements that need to be in place to say that we are providing quality mental health and psychosocial support programming. And some of this essential requirement is developing, planning, and coordinating all aspects of mental health and psychosocial support programming. As I said, in clinical management of rape, the issue of coordinating actors is very important. It's the same with MHPSS. We need to ensure that we are doing proper planning and coordinating with all stakeholders. Why? It's because not all stakeholders will provide all the interventions that are needed by our survivors. There are some who will be working on level 1 intervention. If you look on the right side of my slide, you'll see I've labeled 1, 2, 3, 4. So there are some actors who will be working on level 1, others working on level 2, level 3, or level 4. So we need to all coordinate together so that if I'm working at level 2 or 3 and I see that this person that I'm attending to require specialized services, then I can refer them to those specialized services. So this coordination where we're coming together as MHPSS actors enables that. And then also we need to develop and implement a monitoring and evaluation system to know that whatever we are doing has an impact in the end, and also whatever we are doing is of good quality. Majority of the times, or from the emergencies that I've been to, I see that number 1 is done correctly. Number 2, we're really trying on it. But when it comes to number 3, where is caring for staff and volunteers providing MHPSS services, we tend to lack on that or not prioritize that. While this is an essential intervention that needs to be in place whenever we are providing any type of mental health and psychosocial support services. Even if we are just sending people to provide psychological first aid, we need to ensure that the people we are sending out there, also we are caring for them, we are showing them, or we are equipping them with competencies where they can take care of themselves and not develop burnout or develop, secondary trauma and so forth. And then supporting these MHPSS competencies of our staff and volunteers, because again, majority of the times we tend to work with staff. As I said, I peeped into your Instagram page and I saw that there was some advertisement there asking for volunteers and staff to support in different issues. So if we are using volunteers in MHPSS to provide some MHPSS support of any kind, then we need to ensure that they are equipped with the necessary skills that they need. So going back to our triangle here, or this pyramid that you can see, the bottom part is interventions, MHPSS interventions at level 1. And at level 1, here it's about advocating for basic services and security for the affected population. We cannot talk about, well-being, or talk about, how do you improve, how you feel, if we don't have basics, if we don't have the basics, the shelter, food, health. So we have actors who work on level 1. And in level 1, majority of the affected population would, not majority of the affected population, but a bigger number of the affected population would require level 1 services. And a bigger number here is around maybe 13% to 20% will require level 1 interventions. So we need to ensure that that is in place. While you go higher in the pyramid, in level 2 interventions, it's about community and family support. And here, these are interventions that are promoting social cohesion, community networks, peer-to-peer interventions, because remember that in the disaster, this is affected. The ability for family to connect or support each other or provide this network that they had before is disrupted. So here we see that we need to provide those kind of support and work closely with the community using already existing community practices that already would be highly accepted by our communities. So as UNFPA, we work more in level 2 and level 3, whereby when you see level 3 is focused but non-specialized support that is provided for us as UNFPA to those who are accessing GBV or SRH services. So for focus but non-specialized services, it could include case management services. It includes women and girls safe spaces interventions that are conducted in these women and girls safe spaces. So we have more people accessing these services. So if you go, again, just a reminder to recap, level 1, we have around maybe 13 to 20% requiring that this kind of services. When we come to level 2, the percentage reduces maybe up to 10%. When we come to level 3, we even have lesser percentage on the affected population that will require these services. And the list of this intervention that will be required by our affected community would be the specialized services. So at level 4, we have maybe 4 to 5% of the affected population that will require level 4 services. So again, I see in many of the responses that we concentrate a lot in ensuring that we have specialized services in place, while we know the lower level interventions are more needed by the communities. As UNFPA, we don't concentrate so much on the specialized services. We do have our sister agencies that are working on that, ensuring we have psychologists, we have psychiatrists, we have people who have are bringing in supplies and medication that target specific mental disorders and so forth. But we do more of the community-based interventions and the focus on the non-specialized support, like work with social workers, work with case managers, and so forth. So I hope this is clear to you all. If it's not, please feel free to put something in the chat and or a question, and I will come back to that. So let me put this down. So I wanted again to talk about how we conduct our MHPSS integration in GBV interventions, because as I said, UNFPA highly integrates their GBV and MHPSS interventions, and also we integrate MHPSS in our GBV in our SRH interventions. So in GBV, we integrate MHPSS psychoeducation in our community awareness sessions. So when we are going out there to talk about maybe availability of GBV services, and same for you, if you have any community awareness sessions that you're talking about availability of GBV services, we also need to talk about MHPSS psychoeducation, saying that, it is okay to feel how you're feeling, it's okay to to be anxious. It's okay because this is a normal reaction to a disaster. But if this and this happens, then we need to, come and access this kind of services or those kind of services. So it is very, very important that we promote MHPSS psychoeducation with GBV integration. And then another thing, we also need to integrate MHPSS concerns in safety audits. These are types of GBV assessments. In safety audits or comprehensive GBV assessments, we also have GBV actors conducting GBV assessments, and we want them, when they're out there asking about, GBV, we want them to ask, how are people feeling? How did they used to cope with things before? Has it changed with this hurricane? Has it changed with maybe last week or this month now it's better, and so forth? So we need to ensure that MHPSS concerns and risks are identified in these ongoing assessments. And then we do have targeted activities in women and girls safe spaces to improve well-being of women and girls using age-appropriate empowerment focus, culturally accepted entry points, and so forth. Again, for UNFPA, we're doing more of promotion and prevention of well-being rather than treatment of mental health disorders. Then we do also integrate MHPSS skills in case management services, and also we strengthen the MHPSS skills in community-based protection mechanisms. I'm not sure if these have been set up in Jamaica response, but this is part of what we can do, or we can initiate if there is interest with the ongoing intervention. Then, since we have healthcare providers here who I know are also providing SRH or sexual and reproductive health intervention, I also wanted to highlight how we integrate MHPSS in sexual and reproductive health intervention. So integrating, again, MHPSS psychoeducation during our community awareness session on availability of SRH services. We also integrate MHPSS concerns in SRH or the minimum initial service package readiness assessment. So just to determine if this I mentioned that the MISP readiness assessment looks at whether we are able to establish all the core objective of MISP. So while we are checking on that, we also need to check whether MHPSS risk or concerns have been highlighted or there is services towards that. So again, we also like to integrate MHPSS interventions by improving communication skills of our frontline healthcare providers. I have been to Guyana. I think it has almost a similar setting to Jamaica. Maybe I'm just guessing. But one of the things that I picked in some of the trainings that I conducted there was that doctors were telling me, Suhaila, we have only 10, I don't know whether it was 10 or 15 minutes to see a patient. So we don't have time to, set this in and receive them well. We are like business, like we just want to finish up with the consultation because they're gonna check how much time I'm taking with a survivor, with a patient. But with MHPSS integration, we are saying that we can do both. We can have these communication skills that will help our patients open up to talk about what has happened to them. If we don't receive them well, or if we don't create that right environment, they might not be able to disclose about intimate partner violence or disclose about gender-based violence. So it's very, very important that we do so. And then also we do have MHPSS integration when we are providing services for those with HIV, or we are providing services for STI treatment or family planning. All these are really interconnected. We need to have those competencies to enable us to open this discussion, to create that atmosphere where the one who's in our consultation room is able to open up to us and share their concerns. And then also we do promote MHPSS integration in our emergency obstetric neonatal care, that the EMOC services, by respecting or strengthening the respectful maternity care. We know that women will continue giving birth, women will continue being pregnant. So while we are attending to them, it's still very important that we ensure we are strengthening the respectful care for all the women that will be attending to during this, not only in the disasters, but even beyond that. And lastly, ensuring that we have MHPSS integration on clinical management of rape and intimate partner violence programming. Very, very important. We all know, even just normal talk about, healthy sex is difficult for people. So even much more difficult to discuss sexual violence or to discuss intimate partner violence. So we need to ensure that we are integrating these MHPSS skills when dealing with these sensitive issues such as rape or intimate partner violence. So lastly is to talk about, so how do we bring all this together? How do we ensure we have a harmonized approach on CMR in emergency or on MHPSS in emergency programming? So we are saying we need to have an established shared understanding of clinical management of rape, recognizing that clinical management of rape is a key component for both sexual and reproductive health and GBV programming in emergency. And we support our integration approach. We have seen many times that, maybe priority is given maybe to one and not to the other, but as UNFPA, we promote the integrated approach for SRH and GBV programming. Then also we need to ensure that we are conducting joint assessments and monitoring for GBV, SRH, and MHPSS. I would like to say that these joint assessments is to enable us get more information and specificity, but our initiation of clinical management of rape services or MHPSS integration does not depend solely on on assessments. We already know that this is happening, so we need to ensure that we are setting up the services, we are conducting the assessments to get more insights on the specifics to be able to contextualize or tailor our responses. But this is not a prerequisite for us to initiate the services. Then we also need to have standardized service delivery components, have standard operating procedures for different modalities of care that we'll be offering. I said this clinical management of rape services could be offered maybe in a mobile clinic or in a temporary clinic or in a health facility. So what are the standard operating procedures? Those need to be in place. Then also we need to harmonize data collection and reporting, assigning clear responsibility and tools for who collects and who reports and who summarizes and who, how does data move forward from low level at the health facility level to the health cluster or to the ministry where it's integrated in the DHIS and so forth. Very, very important to ensure that that is happening even during emergencies. Then coordinating training and capacity building. As I said, this is just an orientation. Even if we take the online training, we still, as people who have been in this sector for a long, long time, we still know that there are some tangible skills that we cannot be able to acquire, or tangible competences that we are not able to acquire by just, going virtually and reading or doing a virtual training. But we do need to have, an interactive training that is comprehensive, that covers all aspects of clinical management of rape, collaborating with setting the foundational principles, starting from understanding what is GBV and how does that affect or interact with clinical management of rape and MHPSS and so forth. So I hope in the future you have it in your plan that we will have this comprehensive clinical management of rape trainings or capacity building happening for our frontline healthcare providers. And lastly is to ensure that we have investment and commitment from partners and stakeholders, and of course, including stakeholders like the government, the ministries, and donors throughout the whole response cycle, committing that we are prioritizing clinical management of rape. We are prioritizing, investing in GBV and SRH programming integrated with MHPSS. So I try to be very, very fast. I've included for you references, guidelines, resources, what I thought would be helpful for you, because as much as I'm now doing much more of programming, I was once there. I was sitting in a clinic. I sat in a clinic for 10 years attending to survivors of sexual violence. So I relate. I know where you're coming from. And I really, really feel privileged to have had this opportunity to interact with all of you today. Thank you very much. And I look forward to questions or comments. Over back to you, Kathy.
Thank you so much, Miss Aboud. I'm Dr. Kathy Ann Williams Harrison, and I'll continue the moderation of this session to the end. We just have a few presentations remaining. We're so happy that there's still 87 persons who are on, listening astutely, but we know that you will have to jump off soon. So with no further ado, we're going to have a little break, a little breather with a lovely poetry presentation from Mrs. Stephanie Bernard Stevens. Mrs. Stephanie Bernard Stevens is from the Ministry of Health and Wellness. She is a Senior Director for Planning, Performance, and Project Development here at the Ministry of Health and Wellness. She's also a wife and mother, well-degreed with a postgraduate diploma in health economics and an MSc in applied psychology, and many other accolades. She's a host pastor, and for the purposes of this meeting, she is also a storyteller and a published author of 2 novels and 2 poetry collections. And she will now share with us one of her pieces, just to give us some empowerment within this context. And then we will close out with presentations from other members of the Ministry of Health and Wellness, just some highlights on this information from the Jamaican context, and a presentation from the Bureau of Gender Affairs as well, looking at the Jamaican context. And then we will close out with our post-test. So thanks for bearing with us. I know it's a lot of valuable information, and we will try to wrap up very quickly and expeditiously. Thank you so much for your time. And over to you, Mrs. Bernard Stevens. Thank you so much for being with us.
Thank you, Dr. Williams. Good afternoon, everyone. I just want to share with you a poem. When I was asked to do a poem for this session, I wrote one. I do have poetry books, but specifically for the topic at hand, I would have written this poem when I was asked, and it was titled, I Won't Stay. The storm may be gone, but mine remains. I felt the sting across my face as the sound of the slap echoed through the space. I no longer flinch with shock or surprise. This has become my daily disguise. I remember the first time he hit. His tears flowed, his voice cracked with guilt. Baby, I'm sorry. I love you. Please forgive me. And I did. I believed love was a place where pain could live. But he stopped apologizing when he saw that I stayed. I stayed when I should have packed and walked away. I stayed when his hands grew harder, when the hair grew thin, when silence filled the house and fear moved in. I stayed when his anger became my prison, when love felt like chains I couldn't envision. I stayed when his words became whips, when his rage painted my lips with blood instead of a kiss. I stayed and painted smile over bruises, smile through cracked ribs, practiced excuses. I stayed when my body trembled in dread, when his shadow loomed larger beside our bed. I stayed when his money became my leech, when begging replaced my right to peace. I stayed when the walls whispered, run, but I told myself love would undo what he had done. I stayed when our children watched his fury ignite, his blows landing on me as they trembled in sight. I stayed though their fears cut sharp like knife, tear-swollen eyes marking each battle each night. Then one night I dreamt of my end, a room filled with sorrow, no one to defend. My mother chose a casket, soft cream and pale, no flowers, no laughter, just grief, steady, cold and frail. They dressed me in white, not as a bride, but as another woman who had silently died. No vows, no joy, no open door, just whispers, tears, and nothing more. I watched as my children cried for their mother, now left with the monster that was their father. That dream was my reckoning, my wake up call, my sign. No love is worth losing my life or my mind. So I will not stay another day, no matter the promises, no matter what he says. When fists rise, I will rise higher. When voices shout, I will not tire. I will walk out that door, bruised but breathing, scared but believing that freedom waits beyond fear's gate, and healing begins when I choose my fate. So let this be my vow, my anthem, my plea to every woman, every sister, every me. Choose you. Choose to be free. End the silence, end the pain, because staying is dying and walking away is how we reclaim our names. Thank you.
Wow. I know with poetry, there's snap. So thank you so much for that powerful piece, Mrs. Bernard Stevens. Very empowering. And thank you very, very much, and thanks for your time. We're moving on to our last two quick presentations, Ministry of Health and Wellness and the Bureau of Gender Affairs. And as we transition to those presentations, I'd just like to remind everyone that November the 25th, which will be next week, Tuesday, is International Day for the Elimination of Violence Against Women. And so such an empowering bit of poetry was given a while ago. And these are the themes that we will continue in. So you can watch our social media platforms next week from the Ministry of Health and Wellness, and we will definitely commemorate this day. But we thought it most prudent to have this webinar, even within this context and the context of being post-Hurricane Melissa. So just a reminder for next week, Tuesday, for that commemoration. So our first presentation from the Ministry of Health and Wellness, we just a quick presentation from Mrs. Carleen Temple Anderson, who is a senior director at the Enabling Environment in Health and Client Services branch here at the Ministry of Health and Wellness. And Mrs. Temple Anderson should be no stranger to any of you. Over the past 20 years, she's worked with government, education, health, social development, and private sector. She has a master's in communication and social and behavior change. She's an educator as her first love. She's also an author about self-nurturing thoughts. I need to get that book, Mrs. Temple Anderson. And she's an inspirational speaker, as you'll hear. She's passionate about the treatment of people as human beings. And she's here to speak with us about the social aspects of the response to interpersonal violence, especially in this context of us being post a disaster, post a hurricane, post-Hurricane Melissa. So welcome, Mrs. Temple Anderson, and thank you for your time spent with us today. You may go ahead. Yes, you are good. Once you're at slideshow, you will be good to go, Mrs. TA.
Hi, you can hear me now. That's what I was
Yes.
trying to make sure.
Oh, yes,
All
we can
right.
hear you now, Mrs. Temple Anderson.
All right, so I am now trying to go back on the show. Right, so can
Mhm.
you still see it? Good. So now I'm going to put it in slideshow.
Yes,
Good afternoon,
perfect.
everyone. I'm sorry for the technical difficulties. So without further ado, there's not much time, but I wanted to share this picture with you all just to say, how do we, in this context, the social context of really having a people-centered approach to what we do. And I thought that a pictorial view would be good. So I'm going to walk you through the 7 steps here, and then I'm going to show you where we fall, most of the areas that we fall in that I've already highlighted in yellow with the red marker. So at the beginning of the stage, we are talking about victimization, and this happens through GBV. We are aware sexual abuse. We also have interpersonal relationship violence happening there, and domestic violence. Now, we must recognize that some of these cases that you would receive as healthcare workers are not necessarily because of the Hurricane Melissa. It might have been happening before, and it can also occur during. So we have to also be very aware that anything is possible at this time. But remember, the victims are the survivors that you get. This could have happened before, and it could also be happening during, or it could have started happening during. So it's good for us to have that context. The next thing is, for us, what is critical is once an individual comes in front of us, is to acknowledge their rights. They have rights. And so a people-centered approach, a survivor-centered approach speaks to some basic things that we need to do as healthcare workers. So in everything that we do, we must ensure that informed consent is key. Ensure that persons are very clear what the procedures are that you're going to take them through, any conversation you're having, any information that they're giving. If it's to be shared with anybody else, they need to say yes to it. They need to literally say that they have consented, that you're allowed to share their information, or they must be able to say, yes, I understand the treatment that you're proposing, what the concerns are, and that they are saying yes to it. It's important. If we can document it, it's even a better way to do what we're doing and to ensure that we have it covered properly in terms of their rights. Privacy, I know in this time, we hardly have buildings, we hardly have spaces based on what has happened in some areas for with Hurricane Melissa, but privacy is still a critical part for us. So it's important for us where we are to see if where is that small space, might not be a big space, that we can allow for some privacy when we're doing the consultation. So we still need to figure out in the health facilities, where would this be if this situation occur? If we get a case like this, where do we take this person? And it's key that when we're also working with persons, survivors, that they need to be aware that there are options. So they must also, a part of their rights is also to be able to say, I can choose. Nothing should be forced on them. As much as it's critical, as much as it's important, we still need to allow persons to feel like they have some control. With all that's happening, you still need to allow them to feel that they have some type of control, that the conversations that we're having and how they're able to speak with us, they don't feel discriminated against, and it is a safe space for them to really share their needs and their preference, and for them to be able to say, okay, you have given me these options, but I want to choose this way, or what's the alternative? If you don't have privacy here, is there another facility that I can go to and actually get that level of privacy that I need? That's the type of support that survivors will need, especially during this time. Going across to number 2. So that would be number 1, you as an individual, as a healthcare worker, just being aware and ensuring that when persons come in front of you, they feel like they're being respected and the situation, they're being treated in a dignified way. The other area would be your responsibility for disclosure and reporting. We still have that responsibility. As much as all these things are happening, we still have the responsibility to report the cases, especially sexual abuse. We still need to report it, especially when it's among persons under the age of 16. We have to ensure that we do continue with this obligation to make sure that this is happening. There are other responsibilities in terms of how you disclose as well. Again, you go back to the whole idea of informed consent. Persons must be clear that whatever you're discussing with them, the areas that might end up being disclosed based on the situation. All right. The other areas, so that's number 2. Number 3 that we have here is the healthcare worker follow the MOH guidelines on managing GBV and interpersonal violence. domestic violence, and that will be further discussed with Dr. Williams because that's where we have the information and the guidelines and the management of how we do this. So we're asking that in this situation, as limited as our services might be or restricted, we still need to do our best to follow these guidelines because these are the guidelines that will help to ensure that the survivor gets the best quality treatment. And we have the guidelines in place already. When we move across to number 4, we're talking about location. So referral to support services. So this, you have two type of services. You have the support services that are outside of the Ministry of Health and Wellness, but you also have the support services within the Ministry of Health and Wellness. So you're talking about psychosocial support that we already have present in our system, location of health facilities and other services. We need to ensure that our healthcare workers, especially the customer service team as well, that they're aware of where in this time with limited services or reduced or restricted services at different facilities, these customer service and other persons within the healthcare provider team should be aware of where the possible services are located, because that is where, as soon as the individual is speaking, somebody should be able to provide the guidance and to say, okay, this is where you'd go. So we don't offer it here because of what has happened with Hurricane Melissa, but this is the closest spot for you to go to. This is very, very critical in terms of ensuring continuation of quality care. As we come down to number 5, in every situation, once there is a report, we as healthcare workers must also be available to share during the investigation. So when you get to the stage where you might have to write up the medical legal document around the case, all that stuff. And that's why it's important that at number 3, we definitely follow the guidelines, because if the guidelines are not followed properly, when we get to number 5, there are going to be challenges. And for your survivors, our survivors, to feel confident in our system, we have to ensure that if it reaches the case where it is being investigated at a legal level, especially, we're able to provide the relevant information and documentation that's required for the investigation to go through, and that the survivor will feel satisfied with the service that we have delivered, because it doesn't stop just at the medical. It goes to this case. If it's a case and it's being investigated, this is also a big part of our responsibility. And then as we go down, there is the decision making, which is at the other level. And then even within our system, we need to see what are some of the changes that we might need to make, depending on what the client have told us or the survivor has shared with us in terms of their needs. So as we provide information to the survivor, we're also at this level, number 6, we're also able to say, okay, based on the needs, based on the circumstances that Hurricane Melissa has brought and what is happening with our clients, these are some shifts that we also need to make currently and also for the future as recovery continues. And then at the end, there is the 7, where it's redress and compensation, which again, this is more on the legal justice side. But we might not be doing much in that area at all. Our critical part, though, is to make sure that when the investigation is happening, we have the relevant documents that's needed to ensure that by the time it reached number 7, the decision and the redress action can happen because we gave the relevant information that's needed for it to be effective. In a nutshell, very quick nutshell, that is what something I just, the enabling environment in health and client service division, just wanted to remind us as healthcare workers and other persons on the call, on the webinar, to understand our role and how important it is as we go through a survivor-centered approach to helping GBV and sexual assaulted or abused individuals. Thank you very much.
Thank you so much, Mrs. Temple Anderson, for that very valuable information in a pictorial version, quite comprehensive, and I'm sure everybody learned well. We still have 79 persons on with us. We do understand that some persons had to jump off, but we have this recorded. It's on YouTube now, and so we are going through. I am gonna cut my presentation in. I'll just go very, very quickly, everyone. I'm going to talk quickly about the guidelines that Mrs. Temple Anderson referred to. Again, I'm Dr. Kathy-Ann Williams-Harrison, and I'm the NCD Risk Factor Program Development Officer in the Non-Communicable Diseases and Injury Prevention Unit. So we have guidelines. We have 2 guidelines. They're available on the Ministry of Health and Wellness webpage, and they're also available on the NCDIP webpage. So if you type in NCDIP, you go to resources, or you type in Ministry of Health and Wellness and you go to resources, you can look for these guidelines on the management of interpersonal violence and also on the management of gender-based violence. And you can peruse extensively the information that I'll mention here. We've been through a hurricane in Jamaica. We have suffered displacement, both as it relates to our homes and also as it relates to health facilities. Things aren't exactly how they probably were about 3 weeks ago. We're getting there, but there are some deficiencies. However, the health team stands prepared to continue to provide services for the people of Jamaica. And so we talk about vulnerable groups for violence, and this could be even more amplified in this post-disaster section period. We talk about children, women, men, persons with disabilities, persons with mental illnesses, homeless persons, persons from the LGBTQI community who may be discriminated against, persons in institutions, and the elderly. So we bear those persons in mind in general when we talk about providing care for the management of interpersonal violence and gender-based violence, but we also think about it now being amplified post Hurricane Melissa. And so as healthcare workers, we ensure that we bear these groups in mind, but we still have a close eye on everyone. We need to identify these survivors of interpersonal violence and gender-based violence. They do still present for care. They will be presenting for care in primary care, secondary care. They may give an alert in a shelter. They may be giving an alert at police domestic violence centers, other centers. And as a team, we just need to be aware of how persons may present. Look for the B's: bumps, bruises, burns, and broken bones when we talk about the physical signs. But we also need to bear in mind some of those emotional and behavioral signs, especially in our children. We may have some children that become withdrawn. Children may start doing things such as bedwetting when they would have moved on from that stage before. School performance may have fallen for our children. We look at even the interaction in a facility where someone presents for care. They may present and they may not necessarily be with somebody that they trust. The person may be the perpetrator of the violence. So we keep a close eye for that. And it's not that we're doing universal screening, but we are aware of these subtle signs and these very obvious signs, and we bear those in mind. And then when we think about our adults and adolescents, we can look at the history and the examination as well. Someone presenting with multiple unwanted pregnancies, repeated STIs, and so on. In whatever setting it is, if it is that the facility is partially functional or fully functional, and we have that keen eye to pick up these cases and be able to provide the care in the setting that we're in. So if we suspect it, we're not trying to solve the problem, but we're trying to ensure that persons get their medical care needs met, and they are also referred to the necessary support services, whether within the health sector or for our partners outside of the health sector. As was mentioned before, there need to be standard operating procedures and protocols that are available for persons, and these are provided through our guidelines. And each facility may have something as well, a protocol that they as well follow as guided by these documents that we have. Team members, we have our health records officer who receives the patient. If it is that the patient is stable enough, sometimes they have to go and get medical care first and be stabilized. We have our nurse and our midwife. We have our clinicians. And we have other team members, other adjunct members who play a role, porters or public health inspectors, persons who pick up persons who have been hurt or suffering violence in shelters or staying at a home, or the police may pick up. So everybody is a part of the team, and we all work together to ensure that we're providing that care for survivors of violence. We use the word survivors. So it's not just physical violence that we're talking about. There's emotional, psychological as well, and we bear all of those in mind. Timeline as a reminder for our clinicians as we look at the roles: 72 hours for prophylaxis against HIV, 72 hours for collection of our forensic samples so they can remain viable if it is that we need this evidence, and 120 hours for prophylaxis against pregnancy in terms of emergency contraceptives for cases of sexual assault. So just reminding you of those timelines, you would have picked them up in the pre-test. We have our medical social worker as well as part of the team. And our medical social worker is important, and sometimes that nexus between the health sector and other sectors. They provide that assessment at first for the patient who presents. They do follow-up visits, and they also connect persons with support services that are available within and outside of the sector. The mental health team provides those mental health assessments, those mental status examinations, and follow-up if it is that there is an abnormal mental status examination. Here's a chart that is available in both guidelines, which highlights somewhat of the pathway for survivors. They come in, they have assessed as gender-based violence based on questions that are asked probably in their history or their triage and so on. They're treated by the clinician. They have their mental status examination, and they're referred accordingly to the medical social worker or the mental health team in the case that there's an abnormal mental status examination. And then they are stabilized and connected to other social support services. 1 second. Okay, sorry about that. I'm gathering that the slides weren't projecting. I'm not sure why, so I'm just going to pause for 1 second, reshare, and catch you back up. I hope you would have been able to follow accordingly as I wrap up. All right, just checking with my team. Projecting now. Thank you very much. All right, so I hope you are following with me, team. And all of what I would have said is available in those guidelines. You can feel free to reach out if you want to peruse as it relates to those. So this summary chart here, indicating the team members and how we work together. A reminder that there are cases where reporting will need to be done as mandated by law. And of course, these will be in cases of child abuse. Definitely you call that 211 and you make that call. And the guidelines also indicate the medical legal aspects of gender-based violence, the laws that obtain, and the cases for which reporting is necessary. All right. First line support. We will be familiar with the acronym LIVES. We listen, we inquire about needs and concerns, we validate. We don't let the person think that what they're saying doesn't make any sense. They have experienced it. We may not understand everything that has happened, but we hear what they have said. We encourage them to speak, and we connect to them accordingly. We ensure safety. We talked about the safety plan. And so our nurses and our doctors work together to have these persons safe, whether it's referral to support services, whether it's a plan that we work on with the patient for starters, to ensure that they have a bag with their IDs and other documents so they need to run, Should they need to run to a domestic violence intervention center? Should they need to run to a friend, etc.? And we support, so we connect with support services within the medical setting, outside of the medical setting. We have so many NGOs who are represented here. And LIVES is an acronym for us to remember. So just highlighting the support services, we mentioned police domestic violence intervention centers that are indeed at select police stations, and those are listed on the JCF website. Social services departments, helplines for survivors of GBV, those are listed through the Bureau of Gender Affairs. There are shelters for survivors. There are crisis centers or shelters. There are counseling and emergency hotlines. The Ministry of Health and Wellness has one, which is 888 New Life. And these are listed as well in our guidelines. We have social workers and other members of the team to provide that social and mental health support. We have NGOs and we have church groups, and we also have other key agencies that may be available in your area. Remember, for children who have been abused, they need to stay in the mental health service within the health sector until they are discharged, just so that we can have that close follow-up on them. So that's a quick overview of our guidelines. You can go in detail for the information that is available for these particular guidelines on the management of interpersonal violence and gender-based violence. But we bear those in mind, even in this post-Melissa stage, so that we can be aware of these as we go through this post-disaster situation. So thank you so much. We'll have a question and answer section just at the end of our presentations as we wrap up now. And so our last presentation for the day still have 75 persons on, which is awesome. Last but definitely not least, we have a presenter from the Bureau of Gender Affairs. We have Mrs. Crystal Tucker-Clark, who is a registered social worker, and she's also the director of the Community Liaison Branch at the Bureau of Gender Affairs. So we're so happy to have our ministerial partner joining along with us, or agency partner joining along with us to discuss gender and violence. And Mrs. Tucker-Clark is quite versed in this, having done social and gender impact assessments, strategic advocacy, community organizations. We're happy to have her. And Mrs. Tucker-Clark, over to you. All right, let me assist Mrs. Tucker-Clark as she prepares to share. All right. Let me just make a quick check to ensure that she is coming on. All right. There we
Yes.
go. Hi, Mrs.
Are you
Tucker-Clark.
hearing me? Good afternoon.
Yes,
You're
we're
hearing me?
hearing you.
And you're seeing me. Hi.
And we're seeing you.
All right. I'm trying to share this PowerPoint. Let's go.
There you go. Once you go to slideshow, you're good to go. And thanks for your time.
Okay. So good afternoon, everyone. As indicated, I'm Crystal Tucker-Clark, and my presentation would have been on gender-based violence post-Hurricane Melissa. And I will not go through the entire presentation because most of the stuff were done by previous presenters. However, I look specifically at the work and role of the Bureau of Gender Affairs and briefly touch on some things that our healthcare workers should look out for post-Hurricane Melissa and look as well as our response. So for persons who do not know, the Bureau of Gender Affairs is a division in the Ministry of Culture, Gender, Entertainment, and Sport. And we are located presently at 426 Trafalgar Road in Kingston. And we engage in programs and initiatives that seek to empower Jamaicans and to mainstream gender towards mainstream gender throughout Jamaica towards the development of human capital and the achievement of gender equality and social justice. So As I said, I will not go through this presentation. I'll just take you through post-Hurricane Melissa existing and emerging gender vulnerabilities and look at some risk and warning signs and then go through the response. I'll skip all those other stuff that I have in the presentation. Now, the Bureau, we have several units here. And we have the Community Liaison Unit, the Male Empowerment Unit, the National Shelter Unit, and the Sexual Harassment and Investigation Divisions. Now, all these
You
come
can just go
together.
to slideshow, all right? So we can see the advancement. They haven't shifted yet. And the same thing was
They
happening.
have not.
No,
Oh.
if you do F5 and then you just click on this and go through. Okay, there we are. We're at
You're
policy and
seeing it?
legislative framework. Yes, maybe you can go
Yeah.
back one. Right, there we are.
You're
That's perfect.
seeing.
And then you can just project now at F5.
Okay,
Mhm.
F5. You're seeing everything now?
It's not in slideshow just yet. Or you can click from beginning. Yes.
All right.
And then just
I
go
had
back
to
to
click
the
from
unit.
beginning because it wasn't showing. All
No
right. So
problem.
I was saying to you that we have these units at the Bureau, the Policy and Research Unit, which does policy, research and documentation, gender mainstreaming. You have your Community Liaison Unit, which provides public education and training and awareness raising sessions on gender-based violence. We have the newly formed National Shelter Unit, which provides accommodation and a range of comprehensive services for survivors of GBV. And presently, there are 2 operating shelter and 1 is to be operationalized. And of course, you have the GBV helpline, which provides 24/7 helplines for persons, survivors of gender-based violence that they may call for psychosocial support as well as referral to the shelters. And all this is done within our local and international framework according to our laws and policies in Jamaica that are listed there. Now, I won't go through those because Mary would have spoken about gender-based violence in its entirety. So let's look now at the context post-Melissa existing and emerging gender vulnerabilities that we have seen during our assessment that we've been doing. And these assessments we've been doing is in partnership with UNFP and the other international development partners working with gender-based violence. Now, what we have seen is higher vulnerabilities of women and girls and marginalized groups. We have also seen an increase in care burden that constrains participation in the recovery efforts. A number of persons, including our household workers, many of whom are women, have lost their livelihoods in the areas that are affected by the hurricane, as well as our entrepreneurs, SME, small and medium-sized enterprises, farmers, small-scale producers have also suffered from setbacks.
Mrs. Tucker Clark?
Yes.
It hasn't moved. Same thing happened a while ago. I don't know if it's the connection for both of us. The units within the BGA is what's projecting now. Slide
Really?
4. Yes.
All right.
I don't know if you want to stop share and then reshare. Let's go again.
All right, let's try again.
Sure. So you can just stop share and then we
Stop
see it
sharing,
comes up.
go back here.
Yeah.
You're seeing it?
I'm seeing
Are you
you.
seeing?
I'm seeing you.
All right.
Mhm.
Let's see. Window.
Please do bear with us, colleagues. Some quite valuable information from the BGA, and then we will go ahead with our process. Thank you for still being with us, 72 persons. Thank you so very much, and we pray that you will carry this back to your institutions and share with your colleagues as we work together to build back Jamaica.
Cancel. It's not coming up. It's not coming up. I don't know why. Let us try this.
Can you
Are
see it
you
on
seeing
your
it now?
device? No, can you see
Yeah, I'm
it on
seeing
your
it on my
device?
device. Yes, I'm seeing it on my device.
Maybe you can
but
come out of it on your device, open it back on your device, and then come over to Zoom and share.
All right, let me just minimize this.
We are together, right, Mary? We are together with
We are
you.
here still. Yes.
and then we'll do quite a bit of information this evening, important information, and we're happy that we were able to share with you, everyone.
It's not even showing up in the window for the share in Zoom.
Have you reopened it?
It's open. I'm looking at the presentation, but it's not sharing. We can
Yes.
continue. I'll just share the PowerPoint with you, and you can share it with persons.
No problem.
So I was talking about the existing and emerging gender vulnerabilities. So we are seeing an overcrowding in shelter where we don't have adequate privacy. There's an issue with lighting, and this results in a risk in all forms of gender-based violence. So additionally, displacement and financial strains from Hurricane Melissa may result in increased tension within our household. So you might see a rise in intimate partner violence and those that are reported in your health centers, your hospitals. So, additionally, we would have seen that livelihood, social roles, and sense of identity of displacement are severely disrupted. And within our culture, cultural norms surrounding masculinity and independence, which discouragement from seeking psychosocial support or help will leave them emotional and with mental health needs that are largely unmet. Additionally, what we have seen is a disruption of support services across the areas that are impacted by the hurricane, which means that persons have less access and there's less accessibility and availability of support services that are needed in these cases. So we are looking at in the coming weeks and months that we'll see a rise in GBV report during the recovery period, and these would have been explained earlier by previous presenters. Now, what you as healthcare workers will be looking out for is, give me a minute. Are you seeing the present? It's not sharing still. Huh? Are you seeing my presentation now? No, you're not seeing it. Are you seeing my presentation now? Are you hearing me?
Yes, we're seeing it now, not on slideshow, but you can go ahead.
All right, it's fine. We're seeing it. What? Slideshow. All right, so what you can look out for are unexplained bruises, cuts, and fractures, inconsistent injuries inconsistent with explanation, signs of fearfulness, hypervigilance, avoiding eye contact, partner or family member insists on staying in the exam room, patient seeing distress when partner is mentioned. So these are some of the things you'll be looking out for when you are when somebody may be presenting with intimate partner violence, which is basically violence between persons in an intimate relationship. Now, sexual violence and coercion in shelters or damaged communities, the risk rise due to poor lighting, lack of privacy, and stress. And things that you can look out for are signs of sexual abuse, sudden anxiety, withdrawal, or panic, disclosure of being touched or approached in unsafe ways, or sexual coercion for access to food, water, or assistance, which is often referred to as transactional survival sex. In terms of child sexual abuse and exploitation, you can monitor children who may appear fearful, withdrawn, usually quiet, nightmares, bedwetting. They may have injuries or infections around the genital areas. You might have disclosure of unfamiliar adults around where they are staying, the shelters or the homes. And you may have exploitation for resources, particularly for older teens. They are especially vulnerable. No, elder abuse and other vulnerable persons after this disaster, older adults, persons with disabilities, women and girls may face risks. So you have to watch out for neglect, especially for elders, neglect which presents in dehydration, poor hygiene, malnutrition, signs of physical restraint, caregiver hostility, fear of caregiver presence. And we would have highlighted some of these common issues that you may see: inadequate lighting, broken doors, lack of privacy, and this can result in harassment during bathing, toileting, or collecting water. Girls and women are sleeping in unsafe open areas, and you may have some men and boys. You may have predators, not all men and boys will do this. They will be monitoring women's movement in these spaces. So we need to pay attention to the environmental risk and ask quiet and non-direct questions. Of course, you have the psychological signs of GBV, which are panic attack, crying, visible distress, depression, hopelessness, insomnia, nightmares, shame, guilt, or fear of returning home. Now, as healthcare workers, you are sometimes the first persons that person may come in contact with. So you may have disclosure opportunities. So people might say things like, things rough at home since the storm. We are cramped in one room now. Him frustrated quick. I'm afraid to go back there. So those are some things that you will hear persons saying, and these are invitations for you to probe a little bit more, so you can get the information, so you can refer to the services available within the Ministry of Health, or refer to services outside of the Ministry of Health, like the Bureau of Gender Affairs. So how can you respond? You ensure privacy and confidentiality. You use a survivor-centered trauma-informed approach. You screen only when it's safe to do so. You provide immediate medical care, and you offer referral pathways. And of course, you should be guided by your ministry's guidelines and protocols for the management of interpersonal violence, gender-based violence, and sexual assault. Now we have current services and support. We have a referral pathway here that is being shown on the screen, and it's a referral pathway for survivors of gender-based violence. So if you get a case, you can refer the person to the Bureau of Women's Gender Affairs, and here you have the survivor of violence. The person may seek help, they may tell someone, then it goes to the council, the social worker, the healthcare workers. And we have a multi-sectoral approach. So you have services, you have safety and security services, which are the police, the DVI centers, you have the investigative services. Again, those investigation and prosecution, you have the police, the SOCA, that will do those investigations. You have legal and justice services that fall within these referral pathways, which is legal aid, court, and victim services. So you have Jamaica for Justice, you have the parish justice centers, you have victim services division, and you have the parish court. And of course, over here, you have the medical and psychological care services, or AFTAs, which are your hospitals, your clinics that you are working towards. You see National Family Planning Board here. We know they are subsumed under the Ministry of Health now, so this has not been edited since that. And you have your social protection services, which is counseling, care, case management, shelter, support services. And these actors are like the Bureau of Gender Affairs, Victim Services Division, Women Inc., and other NGOs that may offer these kinds of protective services. Now you have the child care and protection services, which are for persons under the age of 18, where we refer to CPFSA through the 211 helpline. And in case of trafficking in persons, then you have the anti-tip unit and the not for tip, which provides social protection services. In In this referral pathway, of course, you see right here, we have community care services, which the actors in this area are like your NGOs, your FBOs, which may provide food, non-food item, clothing, and other basic needs, as well as support with children and child protection. Now, since the disaster that has happened in Jamaica, what the Bureau's response has been so far, we've been providing basic relief with the support of our partners, specifically UNFPA and UN Women. We're providing basic relief supplies within our GBV programming network, because we are not a relief entity, but we have been providing basic relief supplies, which are dignity kits and care packages. We are also doing psychosocial support and psychological first aid. We also have psychoeducational sessions, and the various departments you would have noted that I said before does public education and awareness raising on gender-based violence. And I just went through the referral pathways and referral services that are available for persons. So once they call the GBV helpline, this is a helpline that is operated 24/7, and persons can get through via call, via text, via WhatsApp, whichever method they use to get to the helpline, and somebody will return the call, somebody will speak to them and assist. Of course, we have the shelters for GBV survivors, and we have livelihood restoration through our projects, which will be done at a later date. But immediately we have been doing these at the top, 1, 2, 3, 4, 5, 6, 7. Those are available now for survivors. We also, as a bureau, has always done capacity building and training in gender-based violence services, referral pathways, and we have been updating and mapping services that are available and accessible in the affected parishes, because we have noted, though we have mapped the services already, some of these services are down and are not available or accessible to persons. So we are updating that list that we'll be sharing with our partners. Now, for help, you have the police, and the numbers are listed there. You have the Bureau of Gender Affairs. Our helpline numbers are 553-0372 or 236-1716. And there's a male helpline, a helpline that is dedicated solely to our men, which is 553-0387. We have the Crisis Center hotline, and those are listed right here. You have the Victim Services Division, and you have the Child Protection and Family Services agencies. So their numbers are listed there. So they all form a part of our GBV response mechanism.
Mrs. Tucker Clark.
Right? Yes.
Thank you, Mrs. Tucker Clark. I know that you're wrapping up, but I know a question
Yes,
came up about
okay.
that last slide. If you could go back to it just for 1 second.
Which
just
one?
So
This
that the
one?
person, yes, they were asking for the
Okay.
helpline number. So colleagues, if you
All
take
right.
a quick screenshot,
Screenshot this one.
you can allow Mrs. Tucker Clark to just move on. But I know that question came up. So please note these numbers, and then you can
those
also,
are the numbers.
Right. You can also Google them as well once you go Bureau of Gender Affairs and so on, and you can get that information. So I think it is.
You can use Google, you can, but these are the numbers. And if somebody call the helpline,
Yes.
and they need referral service, we can refer them to the other support services. So they'll be doing case management as well. So they can refer persons to the Victim Services Division, get somebody from there to assist the Child Protection and Family Service entities. They also do safety planning for persons who are in immediate danger. We also refer persons to the shelter, the national shelter that are operated by the Bureau of Gender Affairs. So these are numbers to have.
Thanks so much. I hope everybody got that screenshot. And if not, look up Bureau of Gender Affairs and you can access it. Thanks.
And of course, these are the numbers for the DV Center and their location. So you can screenshot these as well. These are operated by the Jamaica Constabulary Force. And that is the end of my presentation. I'll share it with you so you can share it when you're sending out the information.
Thank you so much, Mrs. Tucker Clark. So much valuable information. I know that we are way over or 4 o'clock endpoint. We did get quite a bit of valuable information, and we're thankful that 66 persons are on. Thank you, Mrs. Tucker Clark. Thank you to the presenter, Mrs. Tucker Clark from the Bureau of Gender Affairs. Thank you to my colleague presenters from the Ministry of Health and Wellness. And thank you to the UNFPA, the international organization who has supported us for this workshop. And last and definitely not least, we are going to go ahead and do our post-test and evaluation. They're there together in the link. So once you're done with the post-test, you just click next at the bottom and you can proceed to do the evaluation. We crave that information in terms of the evaluation, and we'd love to be able to share your certificates of participation and your continuing medical education credits as well with you. And so please do, the post test is now in the chat, and we'd love for you to go ahead and complete that and complete the evaluation. Thank you for spending the time with us today. Please do get home safely. Please do remain safe and know that there are services that are available for persons who are survivors of violence. There are referral services. And a reminder again for Tuesday, International Day for the Elimination of Violence Against Women. I believe the color that we normally wear is purple, right, Mrs. Tucker Clark? To commemorate
Yes,
that
it's
day.
purple.
So if you have something purple, if that's okay, not for KC this time around, though the Kingston College thing may come up. Case persons who went to Kingston College love their purple. But if you have something purple to carry with you, that would be a good day of commemorating the day. And you can also look out on the social media platforms for us and probably the BJA as well. I know the BJA normally has some stuff that are there in terms of commemorations. You can look out for those from the Bureau of Gender Affairs, from UNFPA, and also from the Ministry of Health and Wellness as we commemorate that day. Actually ends up being 16 days of activism going up into December, where we note this important public health and medical legal issue of violence against women in particular. So be safe, everyone. All the best on your post-test and evaluation form. CMEs have been requested. And once you have put in your email correctly, you should be able to get your certificate probably about 2 minutes after you've completed. So please do go ahead and please feel free to go to the resources section of the Ministry of Health and Wellness and also to our units web page as well to see our guidelines for as it relates to interpersonal violence. And all the best to you. I see a question here from Dr. Henry Dawkins. Hi, Dr. Henry Dawkins. Let me see how we can get your mic open. Or I don't know if you had said something in the chat. No. I'm coming, Dr. Dawkins, right? Let me see, allowed to talk. You can go ahead, Dr. Henry Dawkins.
Good afternoon.
Good
Just saying
afternoon.
that the link that is there, you have to sign into Google. Is there a way to bypass that? So it
Okay.
just goes to the form.
Okay, we're going to try and fix
We're
that.
on the
Just
road, so
no.
it's kind of difficult to do all of that now.
Sure, no
Thank you.
problem. Sure, bear with us, please, and we're going to try and fix that issue right now. If you just bear with us, we're going to try and fix that. Thank you. Okay, thanks, Dr. Dawkins, right? It's requesting a sign in, but what you could do, and anyone else who's having an issue, one, you can indicate to me in the chat an issue that you're having with the post test, and we can see if we can email it to you. So you can just put your name in the chat, name in the question and answer, sorry, and your email address that is connected to it, and we will send you if it is that you're having an issue. An alternative to that is if you're able to copy the link now, it may be an internet thing. You're unable to copy the link. If we'll post it again, and if you copy it, you should be able to try and do it at a later time. The post test will still be up, and you can see if you can do it a little bit later. Okay, so the post test is there again now in the chat. If you hover over it, you can see if you'll be able to copy it over. You can let me know Online Counseling Jamaica, and you can also let me know Dr. Henry Dawkins if you are able to at least copy it and take it from there. Okay, I've seen your email address, Online Counseling Jamaica. So we will be able to send a copy of the post test to you if it is that you're not successful in doing it now. I know 2 persons have gotten through in terms of, well, it's 1, because I know the tester would have been done. So let me just note this email for you, Online Counseling Jamaica. And if there's anybody else who is having an issue, I know Dr. Dawkins right highlighted, and also Online Counseling Jamaica at tutormail.com needs a copy of it as well. What is the name of this training? You can use NCD's. You can use what you see at the top of the screen, which is the training in the management of interpersonal and gender-based violence post disaster. So whatever the name is at the top of the screen, when you go in, you can just use that name, Mr. Mighty. Hope that helps. Oh, mben79@hotmail.com is asking for it as well. Okay. If you didn't do the pre-test, the time would have passed for that. But the most important thing in terms of your credits is your post-test. So please go ahead with the post-test. Once we would have started doing our presentation, the pre-test would have been expired somewhat because we would have started our presentations for your learning. So please go ahead with the post-test. And I see an email here. Again, the name of the training is what you see at the top. Training in the management of interpersonal and gender-based violence post-disaster. So I see just a few emails that have come up, and we will note those so that we can send the post-test and evaluation forms to you. All right. Online counseling, I see you've raised your hand, so we're gonna go ahead and allow you to speak at this time. You can go ahead. You can unmute and go ahead, Online Counseling Jamaica. All right, Online Counseling Jamaica, once you can see your mic, you can go ahead and unmute. Your hand is raised, so I'm thinking you wanted to ask something. Okay, noting what you've said, that if we put it in the Q&A, you'll be able to see it. So let me go ahead and do that. I'll put it in an answer to you, but it will be seen by everyone, and hopefully that will help you. Let me copy and paste that over. All right, let me hope it pastes over nicely. There we go. All right, understood on Online Counseling Jamaica. Is everybody seeing the link now in the Q&A? I placed it in response to Online Counseling Jamaica, but in a way that everyone can see it. Can we get a confirmation? Awesome. So Online Counseling was able to copy it. And I also have email addresses for Dr. Dawkins, right? And some of the other persons who are listed here who were unable to get into the post test. Now that it is in the Q&A section, maybe for the persons who have raised their hands, you could indicate if it is that you have been successful. I'll be here for a little bit more. And so you could let us know if you have been successful, know that it has been posted in the Q&A section. And while that is happening, I'm going to go ahead and just take a glance at the post test to see how many responses. Okay, so the numbers are going up. The numbers are going up. We have 9 responses, so we have a lot more to go. In terms of the 59 persons that are on, but take your time. And we're noting the emails for persons who have not been able to get on. We will send it to you once we close. Okay, it's saying invalid link. It's not invalid. Okay, Online Counseling. Let's see what's happening there again. Persons have been able to complete it. I'm gonna go ahead and click on it now and see what the issue might be. No, I'm guessing in. Okay, you want to try again Online Counseling? Or you can try when we email it to you. Sometimes these things act up, but I see where persons have been able to complete it Online Counseling Jamaica. So I'm not sure why it's coming up as invalid. What exactly is the message that you are getting? In now, awesome. Awesome. Thanks, Online Counseling. So it will be Dr. Dawkins, right? And also the other persons that are listed here in terms of the email. Now that I have a pause, I'm going to try and get the link out to you. But please, if you can check back by the latest 7 p.m., you should be able to access it. That being the latest. Once we close out, I'll send the email. I see another raised hand. Hi, Dr. Diane Jackson. Please go ahead.
Doctor, I just wanted to know, what is a pass mark out of 16? What's the score out of 16 that gives you a pass?
It's out of 16, so we look for a score ideally of 80%, but we'll peruse what has come in. 80 would be awesome, 80%. So 80% of 16, if I do some quick math. But tell me, is there an issue? Has an issue come up? Or if you want to tell us off air, that's also okay.
No, there's no issue. If 80 is a pass mark, then I'll just leave it at that.
Not really a pass mark, but that's what we would really ideally have in
Okay.
so that we know that the knowledge has been transferred. So that's
Okay.
about 13 out of the 16.
That's correct.
Yes,
Yeah.
yes. All right, but we'll see everybody's thing.
And
We
I
want
gather
yes.
this test doesn't allow you to repeat until you get a better.
No, unfortunately, but we will review and we will
Okay.
reach out if needs be to persons so that we ensure that we have everybody up to
No
speed.
problem. Thank you.
No problem, Doc.
Mm.
All right, so I don't see any more questions, which is good. The post-test is in the chat. I think everybody's probably doing it now. And I'm just gonna take the opportunity to note these email addresses that have come up. I don't need to send it to online counseling again because online counseling Jamaica was able to get in. So I'm still to send to Dr. Dawkins, right? Oh, Dr. Dawkins, right? Got in on another device. Awesome. So let me see who remains. A few persons had their emails up. Seems like those persons got through. I'm not seeing the requests anymore. Anyways, we will peruse and see. If it is that you haven't gotten in, colleagues, to do the post-test and evaluation, I'm going to ask at this point if you can just go ahead and raise your hand so that we can know that we need to project it again. Okay, thank you so much, Mrs. Aboud, for presenting today. Thank you so much, all the way from Istanbul. That's awesome. Dr. Maria. All right. Dr. Maria has raised her hand. That's the first hand that I saw. So let me allow Dr. Maria to speak. You can unmute and speak, Dr. Maria. Dr. Maria, you can.
Good evening.
Sure. Hi.
Yes, I'm trying to get on to do the post test, but I can't get on. So I wanted to find out how I can get on, please.
Okay. Are you seeing the link?
Yes.
Were you able to click on it?
Yes. And it went to a Google site, but when I typed in my email, after that, I couldn't move forward after that.
Okay. Are you on a phone or on a laptop at this point?
On a phone.
Okay. I think the best thing to do, Dr. Maria, if you could type your email address in the Q&A, the one that you're using, the one that you're using, then we can send the link to you via a email.
Okay.
So if you just go into
that.
Q&A, type in your email, we will send you the link via email right when we close in a few.
Okay, thank you.
You're welcome. I know a hand was raised by online counseling. Online counseling Jamaica, you can go ahead.
Hello, can you hear?
Yes, this is online counseling.
Yes.
Sure.
Yes, if there's no Google account, what happens? Because for those who don't have a Google account, there's a problem for if it says sign in.
I don't know why that is coming up. But again, if persons are having an issue going in and the Google issue comes up, please share your email address and we'll try to get the questions to you so that you can complete your post test. So please, if there's anybody having an issue getting in, Dr. Maria has indicated Dr. Maria is going to share her email address. If you have any issue with the post test and evaluation, please type in your email address, the one that you used maybe for the pre-test. If you have a Gmail, if you have anyone, it shouldn't be flagging you, but I gather it happens with some devices. So please share your email address so that we can share it with you. One person who indicated they were having an issue, when they tried on another device, they got through. So, you know, it is what it is, but please, we would love for you to be able to complete both the post test and the evaluation So please share your email address, and then we will be able to send the link to you. We're going to wrap up shortly. Let me see where our numbers are in terms of the post test. I see 27 responses, so that's awesome. So a few more persons completing, probably doing the evaluation. So again, if you have an issue, please indicate in the Q&A, share your email address. We'll still get around this online counseling Jamaica. We will look to see if we can get the email addresses for the persons having an issue, and then we'll have a line of communication that way so that we can get the post test to you and we can get your responses. All right, very valuable. And we want to ensure that knowledge has been transferred. Not seeing any email addresses popping up in the Q&A. Don't know if that means, seeing Dr. Maria, no? Thank you, Dr. Maria. There were some emails before that I'm not seeing, so I trust that it means that person's got through after clicking on the link. And what we will do is close this platform though it's now 5:20, we'll definitely close this at 5:30. So I need to send an email to Dr. Maria. I'm not seeing any more email addresses that I need to send it to here. So I trust persons have gotten through after trying. Dr. Dunkley. Hi, Dr. Dunkley, you can go ahead.
Hi, Doc. I was just asking,
Hey.
good afternoon, everyone.
Hi.
I was just asking if you could post again, the post test link in the chat because I lost connection and no, I can't see anything before.
Sure. You want me to share it in the Q&A? Q&A is okay? Or in the
Anywhere
chat?
is fine, Doc.
Anywhere?
It doesn't.
All right.
Anywhere because I'm just gonna check for it.
Okay, I think it was right.
Okay, I
Dr.
sent
Dave.
it to you. No, Dr. Carr sent it. That's it.
Yes, that's
All
it.
right. Thank you so much.
Thank you, and thanks for being here.
You're welcome. No problem.
Yes. Right. So just Dr. Maria's email that I'm seeing. So let me go ahead and just do it that way. All right. And I think I'm going to wrap up. So I'm just going to drop a note to my team members. Please. New hand? Dr. Dunkley, is that a new hand? Is that a new hand, Dr. Dunkley, or are you okay?
Sorry. Let me lower that.
Legacy hand? Legacy hand. Okay, just making sure. Thank you, because I had stepped away. Thanks. Okay, Dr. Maria, I'm going to take my little break and give you the email now. Let me just pull it up. dermatologyantigua@gmail.com. All right. dermatologyantigua@gmail.com. Okay, so it should be coming over to you now, Dr. Maria. You should see it in about 10 seconds now. And I trust you'll be able to complete.
Yes, I just got it. Thank you.
Awesome. Could you tell me if you are able to get in?
Just downloading it now.
Okay, awesome. M Benz, I don't know if that was is M Benz still on? I'm just gonna go ahead and send it to mbenz@hotmail.com just in case. mbenz79. And please know that the evaluation is also there as well, right behind the post-test. So grateful if you would go ahead and just complete. Once you're done with the post-test, there's a button that says next. It goes right into a few questions for the evaluation. All right, I think that is everybody. Persons are slowly jumping off. I've sent it to the email addresses that I saw with the request. Let me make sure. Okay, I need to send it to one more. Mick Burke. That's for Mikhail Burke. All right, I'm gonna send it to Mick Burke. Nope, a little bit more.
Still can't see for online counseling in email, thanks.
Oh, did you get, if you got through, I didn't send it to you. You got it, if you got through already? You got through?
No, I didn't. I'm still trying to see if I can get it on the email on a different device. And I didn't see it in the email. Thanks.
No, I didn't send it to you when you had said you had gotten through,
No,
or I
yeah, but
thought you had
but
not
then
getting
it came up
through.
with, yeah, it came up with I have to be logging into Google and all that.
Okay, no problem.
Thank
I'm
you.
going to send it to you, and I'm also going to send it to this request for Mick Burke. So unfortunate, because I know some persons have gotten through.
Thanks.
All right, no worries. All right, so I'm gonna send this to you. All right, coming up. Coming up, online counseling. All right, I'm gonna send it as a BCC. All right, just so that you can both get it at the same time. All right. All right, and also for online counseling, your email address is onlinecounselingjamaica@tutormail.com. I'm not familiar with tutormail.com. Is it fairly new? Online counseling Jamaica at tutormail.
It's a Swiss site for
It's a sweet
confidentiality.
site. Got you. Online counseling Jamaica at tutormail.com.
Yeah.
All right. Online counseling Jamaica at tutormail.com. All right, I'm gonna send it now. There's a bit of a 30-second delay. So post link and a post test and evaluation. Webinar. All right, I'm about to hit send. Just giving it a title so it doesn't come to you dry. All right, Miss Online Counseling. Let's see if you get through. No, give it 30 seconds and it should come over to you, all right? Mhm. All right, persons are dropping off. Let me see if it has been sent now. Any luck online counseling in your inbox?
Not seeing it yet, but I guess it may take a while. I don't know.
Mm-hmm.
What if I try to do the pre-test again? I'll do it as honestly as I can. That I remember. Does it come up
It's
again?
just that this
Does
one
it?
has a little bit more information.
No, but what I mean is, if you do the pre-test, which I have on screen here, does the post-test come up afterwards, immediately, or consequently, or?
It's a separate link.
Oh, it's a separate, but I don't know then.
It's in my sent to you, so you should see it soon.
Okay.
You should see it soon,
Okay.
Doc. I see it. For the other person that I sent it to, there's a delay via Hotmail. Maybe you can look in your junk. I don't know. Your junk mail. But I know it has gone through to most persons. When I look back,
Okay,
let me
did
see
I
how
get
many
junk mail?
respond. Seeing it now?
I know I have to go and check that junk mail.
Okay. We're up to 42 responses. So I know persons have been getting through. It's probably just a few little glitches for some persons. All right, I'm gonna stop the recording. And what I'll do, online counseling Jamaica, is I am going to
Got it, but still again, I have to sign in and I don't have a Google account.
All right, let me see if Google can help me. Oh, but you got into the to the pre-test, okay?
Yes, yes. Yes, I did.
Okay. Miss Online Counseling Jamaica, there's a way around it. For the emails to which it is not going. But
No.
it could affect the persons who are using their Gmail. So if you bear with me, I'm going to just allow for persons to complete it this evening.
Yes.
I have your email address. So
Okay.
first thing in the morning, I'll make a tweak to the setting that
Okay.
will allow you to be able to get it, all right?
Okay, thank you very much.
Sure. I'm going to type my email in the chat so
Okay.
that if anything
Okay.
changes, I
Okay.
know you can reach out to me if you're not seeing anything by end of day tomorrow. All right.
Okay. Okay.
So here it is. It's my name without the Harrison. Kathy-Ann.Williams. Just confirm for me, please, Miss Online Counseling Jamaica, that you see it. My email address popped up a while ago.
Well, it should be right in my email itself because I got the email.
Ah, I thought it didn't go through. Correct.
No.
No problem. Right? So if you don't see anything from me by about 2 o'clock tomorrow afternoon, worst case scenario, please just shoot me a little reminder and I'll try and get it to you. All right? Thanks so much for your patience.
Well, thank you for yours because this is an odyssey of rubbish.
No problem. All the best, everyone, and take care now.
Okay.